I think that diphenhydramine. What do you think? Every secretion is drying down. Okay. This patient is with high risk of with high risk of overdose, bipolar disorder, substance use disorder, has symptoms consistent with anticholinergic toxicity, including the following: confusion and visual hallucination, picking at imaginary object, mad as an hatter, blurry vision likely due to mydriasis, blind as a bat, hyperthermia from impaired heat dissipation, hot as a hair, dry mucous membrane dry as a bone, and urinary retention full as a flask. These symptoms occur due to competitive blockade of muscarinic acetylcholine receptors in the CNS ciliary body of the eye, salivary glands, and detrusor muscle because of similar antagonism of muscarinic receptor in the sweat glands, heart, and intestinal muscle. Dry skin, tachycardia, decreased bowel function, decreased bowel sounds are common. Toxicity often occurs when anticholinergic medications are taken in excess, overdose, or when multiple anticholinergic medications are combined. Among the many medications with anticholinergic property, some of the readily available and commonly used antihistamine as diphenhydramine. Acute, tox- acute toxicity of the lithium can cause neurologic finding, including confusion and ataxia. However, acute toxicity typically also causes GI symptoms, nausea, vomiting, diarrhea, and hyperthermia, and urinary retention are not expected. Wernicke-Korsakoff syndrome, secondary to alcohol use disorder, can cause confusion, visual changes from ophthalmoplegia, gait ataxia. However, hyperthermia, dry mucous membrane, and urinary retention are not classically seen. Yes, common agents of anticholinergic properties: diphenhydramine, cyproheptadine, psychotropic drugs, chlorpromazine, haloperidol, second generation clozapine, and tricyclic antidepressant like amitriptyline and clomipramine. Antiparkinsonism, benztropine trihexyphenidyl. Antimuscarinic, there may be protropium, oxybutynin, darifenacin, dicyclomine, hyoscyamine, scopolamine, mydriatics, atropine, cyclopentolate, plant-based muscarinic mushroom species, Jameson wood nightshade species. This patient has a history of recurrent infection and failure to thrive. Recurrent infection and failure to thrive in infancy is concerning for primary immunodeficiency, which can involve a defect in B cell, T cell, or both. B cell immunodeficiency presentation classically occurs after age 4 to 6 months when maternal antibodies wane. Sinopulmonary infection, acute otitis media, pneumonia caused by encapsulated bacteria are typical due to lack of opsonizing IgG and mucosal IgA. T-cell immunodeficiency presentation typically occurs in early infancy with severe bacterial, viral, and fungal pneumocystis jirovecii opportunistic infection failure to thrive and is usually present due to chronic diarrhea and increased metabolic needs for recurrent infection. This patient's recurrent acute otitis media since age 5 months is an indicative of decreased B cell and low IgA, whereas pneumocystis jirovecii pneumonia is suggestive of decreased T cell. Therefore, combined B and T cell disorder is most likely in this patient. In the presence of ocular telangiectasia, collection of dilated blood vessels, his findings are most consistent with ataxia telangiectasia. Ataxia telangiectasia, an autosomal recessive disorder where defective DNA repair results in cerebellar ataxia, oculocutaneous telangiectasia, recurrent sinopulmonary infection. Immune defect are variable and can variable and can affect both humoral and cellular immunity. As seen in this patient, lymphoid tissue is often small, non-palpable due to lymphopenia. Okay. This adolescent with encephalopathy, confusion, abdominal pain, vomiting, blurred vision, and markedly serum bicarbonate, indicating metabolic acidosis. A significantly elevated CAP 29 denotes anion metabolic acidosis. The most common AGMA in adolescent is Now, type 1 diabetes is complicated by decay, which could explain the symptoms. However, normal serum glucose and negative ketones exclude the diagnosis. Another potential cause of AGMA is ingestion of toxin, alcohol, ethylene glycol, methanol, which is common or suicidal, which is common in patients who are suicidal and seeking in inebriation make lack of access to ethanol financially and methanol ingestion is highly likely in this patient given the ophthalmoscopic finding optic disc hyperemia, which signifies optic neuritis caused by formic acid. Famipizole, famipizole can famipizole can be famipizole can be used to inhibit famipizole can be used to inhibit methanol metabolism into formic acid, and hemodialysis can be considered in severe cases, although early treatment can partially reverse the vision damage and fully recover is rare. Okay, yes. Toluene is sometimes inhaled recreationally. Toluene is sometimes inhaled recreationally, glue sniffing, particularly among adolescents, because of ease of access. Although encephalopathy and abdominal symptoms can occur, optic neuritis would be rare. In addition, non-anion metabolic acidosis, not AGMA, would be typical, caused by toluene-induced type 1 RTA. AGMA can occasionally be seen in severe toxicity associated with kidney failure or lactic acidosis, both of which are absent in this patient. Okay. This patient recurrent bacterial infection, severe periodontitis, and marked leukocytosis are consistent with leukocyte adhesion deficiency. Leukocyte adhesion deficiency is caused by defective integrin on the leukocyte surface, which normally allow neutrophil adhesion to the vascular endothelium, exit from the vasculature, and migration to an area of infection or inflammation. Lack of neutrophil migration in LAD classically presents in the neonatal period, which with delayed umbilical cord separation, age more than 3 weeks due to poor wound healing. However, this may not occur in patients with mild integrin defects. In in these patients, presentation may not occur in early childhood with recurrent skin cellulitis, omphalitis, and mucosal periodontitis reflecting the skin and oral mucosa susceptibility to bacterial invasion. Infected tissue characteristically lacks purulence, as seen in this patient history, and chronic infection can lead to ulceration and necrosis. Serum studies show marked peripheral leukocytes and neutrophilia, particularly during episodes of infection, reflecting impaired mobilization. Absolute lymphocyte and monocyte counts are normal as seen in this patient. Biopsy of the infected tissue show inflamed but no neutrophil cultures often grow staph aureus and gram-negative bacilli. Okay. Yes. Leukocyte adhesion deficiency. There is defect in CD18 containing integrins, impaired leukocyte adhesion and endothelial transmigration. Clinical feature is skin and mucosal infection, cellulitis, periodontitis without pus formation, impaired wound healing, delayed umbilical cord separation, age more than 3 weeks. There is leukocytosis and neutrophilia. Okay. These patients acute onset of increasing anxiety and restlessness, and physical examination finding jitteriness, diaphoresis, bradycardia, hypertension, and increased muscle tone and hyperreflexia are consistent with serotonin toxicity, likely due to combined effects of to serotonergic medication. Sertraline is a selective serotonin reuptake inhibitor for a generalized anxiety disorder, and tramadol is an analgesic medication with serotonergic activity. Serotonin toxicity is mild to potentially life-threatening syndrome associated with excessive serotonergic activity that can result from the use of serotonergic medications alone, in combination, or from intentional overdose. The onset is typically within 24 hours of intake a serotonergic drug or changing the dose. The diagnosis is made clinically based on the classic triad: mental status changes such as anxiety, restlessness, agitated delirium; autonomic dysregulation such as diaphoresis, tachycardia, hypertension, hyperthermia; neuromuscular hyperactivity such as tremor, muscle rigidity, clonus, and hyperreflexia. Generalized symptoms: diarrhea, hyperactive bowel sound due to stimulation of serotonin receptor in the gut are common. Serotonin toxicity: serotonergic medication, especially in combination SSRI, SNRI, TCA, tramadol, drug interaction, serotonergic medication, and monoamine oxidase inhibitor or linezolid; intentional overdose and of serotonergic medication, serotonergic substance MDMA, dexmethorphan, and amphetamine; mental status changes, anxiety, agitation, delirium; autonomous dysregulation, diaphoresis, hypertension, tachycardia, hyperthermia, vomiting, diarrhea; neuromuscular hyperactivity, tremor, myoclonus, hyperreflexia. Management is discontinuation of all serotonergic medication, supportive care, sedation with benzodiazepines. Serotonergic antagonists if prohibited if supportive measures fail. Immediate sedation, paralysis, and tracheal intubation if temperature is more than 41 degrees Celsius or 106 degrees Fahrenheit. Sorry, this patient, uh, this patient with chronic pain has altered mental status, hypertension, signs of anticholinergic toxicity, facial flushing, dry mouth, and a prolonged QRS interval. prolonged QRS interval. These clinical features suggest tricyclic antidepressant poisoning, TCA poisoning. TCA are frequently prescribed for migraine prophylaxis. TCA exert their antidepressant effect by inhibiting the presynaptic neurotransmitter reuptake. However, they interact with multiple other receptors leading to characteristic manifestation of TCA overdose. In addition, TCA can block the cardiac fast sodium channel. TCA can block the cardiac fast sodium channels, resulting in conduction abnormality QRS and QT prolongation, which can lead to fatal arrhythmias, ventricular arrhythmia, ventricular fibrillation. Management of tricyclic antidepressant poisoning includes supportive care, telemonitoring, IV fluid, benzos if fever occurs, In addition, where the QRS interval is more than 100 milliseconds, IV sodium bicarbonate should be given. IV sodium bicarbonate should be given to shorten the QRS interval and reduce the risk of fetal arrhythmia. Sodium bicarbonate alkalinizes the plasma, which favors the non-ionized form of the drug, makes it less accessible to bind sodium channels. It also increases the extracellular sodium concentration, which helps overcome the sodium channel blockade induced by TC. Atropine is indicated in OPC toxicity, which also presents with altered mental status, typically after exposure to agricultural pesticides. However, signs of anticholinergic excess, salivation, urination, diarrhea, bradycardia would be expected, and QRS interval widening is not typical, and calcium chloride is indicated for treatment of severe hyperkalemia. In addition, in addition to insulin with glucose and beta agonist, it is also indicated for calcium channel blocker overdose. Calcium channel blockers are often used to prevent migraine. Hyperkalemia causes arrhythmia and QRS interval widening, but typically produces other ECG finding, peaked T wave. Calcium channel blocker overdose frequently causes hypotension and AV block. However, neither hyperkalemia or nor calcium channel blocker overdose would cause anticholinergic symptoms. TCA, tricyclic antidepressant CNS, cause mental status changes, drowsiness, delirium, coma, seizure, respiratory depression, cardiovascular sinus tachycardia, hypertension, prolonged PR, QRS, QT interval. There may be arrhythmia, ventricular tachycardia, or fibrillation. Anticholinergic, there is dry mouth, blood, vision, dilated pupil, urinary retention, flushing, and hyperthermia. Management is supportive care and therapy, supplemental oxygen, intubation, IV fluid, activated charcoal for patients within 2 hours of ingestion unless ileus present, and IV sodium for QRS interval widening for or ventricular arrhythmia. Okay. The immunoglobulin and lymphocyte says all. So in CD4 ligand like hyper IgM syndrome. So IgM syndrome, so IgM is high and rest is low and B cell is normal because CD40 ligand is both B and T cell deficiency. No, no, no. Oh, sorry. Hyper IgM. It is, sorry, it is T cell deficiency, not B cell. So that's why B cell is normal. And CVID, we know that B cell count is normal, but the game is low. And selective IgA selectively decreases IgA and rest is normal. Hyper IgE job syndrome, IgE is high and rest are normal. Okay. Oh, okay. This patient has recurrent sinopulmonary infection, markedly low serum immunoglobulin and decreased B cell. These findings are consistent with X-linked agammaglobulinemia or Bruton agammaglobulinemia, a genetic disorder characterized by a defect in tyrosine kinase B cell. This defect results in failure of bone marrow pre-B cell to mature into circulating CD19 B cell, leading to low immunoglobulin production. When protection from maternally derived transplacental IgG antibody wanes at age 3 to 6 months, patients with X-linked agammaglobulinemia develop recurrent sinopulmonary acute otitis media pneumonia and gastrointestinal salmonella campylobacter infection. Physical examination in children aged more than 2 with X-linked agammaglobulinemia is remarkable for underdeveloped or absent lymphoid tissue, tonsil, adenoid. Notably, these tissues are not prominent even in healthy children aged less than 2. Lab finding consistent with X-linked agammaglobulinemia, low serum IgG, IgM, IgA, impaired antibody response to vaccine, and markedly reduced CD19 B cell. T cell count is normal. Detection of BTK gene mutation confirms the diagnosis, and treatment is immunoglobulin replacement therapy (IVIG) with or without prophylactic antibiotics. Transient hypogammaglobulinemia of infants is characterized by decreased IgG, variable IgM, and normal IgA and B cell concentration. Affected patients develop mild recurrent sinopulmonary and gastrointestinal infection. Immunoglobulin levels are generally normalized by age 9 to 15 months. Okay, heat exhaustion. Okay. In exertional heat, look at the option B first. This patient with no CNS dysfunction and no hyperthermia, like temperature and hyperthermia, temperature less than 40 degrees Celsius, has heat exhaustion, not exertional heat stroke. So, like in heat stroke, there is CNS dysfunction and hyperthermia. Temperature will be very high. In here, temperature is 102. Like in fever, you may have this 102 temperature, isn't it? But 104 is very abnormal. So, if temperature is more than 104, then a heat stroke, maybe that's yes. And it is heat exhaustion due to as he played in the outdoor game, and there is uh, history of cystic fibrosis, lots of thing is present. So this patient with cystic fibrosis developed nausea and pre-syncope associated with hyperthermia, nausea pre-syncope associated with hyperthermia, tachycardia, tachy hyperthermia, tachycardia, tachypnea poor while playing soccer, suggestive and exertional, suggesting an exertional heat illness. Although exertional heat stroke may present in a similar manner, the absence of CNS dysfunction in this patient, suggests she has heat exhaustion. Heat exhaustion typically occurs after prolonged exercise soccer in high ambient temperature, particularly in the setting of high humidity, which limits evaporative cooling from sweat. like like other heat related illness, heat exhaustion risk factors include older age, obesity, poor physical fitness, infection, and certain medications anticholinergic. In addition, cystic fibrosis may predispose patients to heat related illness due to higher rate of sodium and chloride lost in the sweat. Heat exhaustion is characterized by hyperthermia. Typically, the patient's temperature is moderately elevated, but is usually less than 40 degrees Celsius. Common manifestation of heat exhaustion will include weakness, dizziness, or profuse sweating, headache, and nausea, vomiting, tachycardia, tachypnea are common. And hypotension may occur. Unlike exertional heat stroke, mentation remains normal. Management includes cooling the patient, air conditioning, cool water shower, oral hydration with chilled salt containing fluid should be encouraged due to fluid and sodium losses that occur with sweating. Individuals with cystic fibrosis excrete excessive sodium and chloride in their sweat. As a result, their increased risk for dehydration, exertional hyponatremia, and hypochloremic dehydration are not hypernatremia and hyperchloremic dehydration. Infants with cystic fibrosis are particularly susceptible to hyponatremic dehydration even without heat stress. Okay, acetaminophen overdose. Acetaminophen overdose time since ingestion. If it is less than 4 hours, then administer activated charcoal. If it is 4 or more than 4 hours, if it is 4 or more than 4 hours, check acetaminophen level. Check acetaminophen level 4 or more than 4 hours of post ingestion. Consider impaired and acetylcysteine. Any evidence of liver injury, ASTLT, or right upper quadrant tenderness. 8 or more than 8 hours since injection, or acetaminophen level not available, not available until more than 8 hours of post injection. Acetaminophen levels available. Plot level on Rumac Matthew normogram. Plot level on Rumac Matthew normogram. Administer N-acetylcysteine if level is above the treatment line. Mm, the treatment. Okay. So mm, this patient was brought to the emergency department an hour after ingestion of potentially toxic single dose of acetaminophen. Toxic single dose of acetaminophen more than 7.5 gram in adult at an early stage. A patient with acetaminophen intoxication can be asymptomatic and may have only non-specific symptom nausea, vomiting, anorexia, not until 24 to 72 hours after ingestion. Doses hepatotoxicity typically becomes evidence with rising of aminotransferase level. The levels then peak at 72 to 96 hours and may be associated with hepatic synthetic dysfunction, prolonged eating and INR, hypoglycemia, and lactic acidosis. A patient who obtains care within 4 hours. A patient who obtains care within 4 hours of ingestion should be administered activated charcoal for gastric decontamination. Although activated charcoal Although activated charcoal is most effective if administered an hour, within an hour, evidence suggests a reduction in liver toxicity if it is given up to 4 hours of post ingestion. The acetaminophen level must be measured at 4 hours of post ingestion. Earlier levels are unreliable for preceding toxicity and plotted in the Rumac-Matthew normogram. If the plot Rumac-Matthew normogram, like treatment line, if the level plots above the treatment line on the normogram, the antidote N-acetylcysteine should be administered. So initially we do not add the N-acetylcysteine. Just we give the activated charcoal and wait for and we are making the graph and we are seeing that if there is any sort of uh, ALTL, ASTLT rise or PTT rise, isn't it? And this Rumek Matthew normogram is important. Like it is done after 4 hours, like we are seeing the acetaminophen level, isn't it? Okay, if the acetaminophen level is 200, like, then we should give the N-acetylcysteine, isn't it? Like, okay, I got it. Next. Okay. Children are typically exposed to lead through inhalation or ingestion of lead particles from the environment. They are at increased risk of lead poisoning compared with the adults due to an incomplete blood-brain barrier, or increased mouthing of objects in their environment, and increased gastrointestinal absorption to lead. A risk factor for elevation risk factor for elevated lead level is living in a home built before 1978, especially there is a peeling paint dust released from dust released during renovation. Other risk factors include lead piping, having having a parent who works with batteries or pottery, and having a playmate or sibling with a history of lead poisoning. Patients who are symptomatic from lead toxicity can have anemia, abdominal pain, encephalopathy. Targeted screening of high-risk population, regardless of symptoms, is important, as most children with lead toxicity are initially asymptomatic but can have cognitive and behavioral problems that become apparent after school entry. Capillary blood specimens are widely used in screening for lead poisoning, but false positive results are common due to environmental contamination and improper collection. Confirmatory venous lead measurement is required to confirm the diagnosis of elevated lead level. If a concerning if a screening capillary lead level is more than 5 microgram per day. Okay, this patient does not meet the criteria, meet the threshold for chelation therapy, although he is still at risk of cognitive impairment. Chelation therapy is not routinely administered for lead level less than 45 microgram per day due to lack of evidence for improved neurologic outcomes. Sorry, improved. Where I am. Okay, dimer captosuccinic acid. Succimer is typically used when lead level uh, are 45 to 69, and dimer-caprol plus dimer-caprol plus calcium disodium EDTA should be administered on an emergency basis for level more than 70 and or acute encephalopathy. Okay, yes. Lead poisoning, home built before 1978, home built before 1978, pica or mouthing behavior, sibling with lead poisoning, low socioeconomic status, immigrant or international adoptee, maybe asymptomatic abdominal pain, constipation, cognitive impairment, behavioral problems, encephalopathy. Mm, clinical feature maybe asymptomatic abdominal pain, constipation, cognitive impairment, encephalopathy. Management is obtained venous sample if screening performed by capillary sample. Environment surveillance, identify and remove lead exposure, notify public health department, nutritional counseling, chelation therapy if it is more than 45. BP is low. We give, what is our diagnosis? We give fluid. Is it naloxone? Opioid. This patient with a fever, pansystolic murmur at lower external fever, pansystolic murmur at lower external border, and or evidence of IV drug abuse likely has infective tricuspid valve endocarditis. His subsequent acute change in mental status, respiratory depression, and meiosis suggest opioid intoxication. Meiosis suggests opioid intoxication, and decreased respiratory drive is the most predictive of opioid toxicity. The, di- um, the disorder may attempt to obtain drugs from outside the hospital system via visitors, especially if they start feeling withdrawal symptom. Opioid intoxication is a clinical diagnosis. Opioid intoxication is a clinical diagnosis when it is suspected. An opioid receptor antagonist should be administered immediately without delay for urine toxicology screen or other diagnostic workup. The goal of naloxone therapy is restoration of the ventilation and not resolution of all other symptoms. Return of mental status or to baseline. This can often be achieved by titrating to effect with smaller doses. Larger doses can induce withdrawal. Naloxone has short half-life and may need to be re-administered if respiratory depression returns. Yes, opioid intoxication. Opioid intoxication is substance use disorder, chronic opioid use, substance use disorder, chronic opioid use, hospitalization, especially post-operative and renal and hepatic and renal insufficiency. There may be somnolence, altered mental status, pinpoint pupil meiosis, shallow breathing, pinpoint pupil meiosis, shallow breathing, bradycardia, hypothermia, decreased bowel sound, respiratory acidosis on ABG. Naloxone may need repetitive administration, airway management, and ventilation. Exclude other cause of exclude other cause. Okay. These patients clinical presentation with small This patient's clinical presentation with small ulcer developing at the site of recent bite is clearly suggestive of brown recluse spider bite. Such bites commonly occur in patients are putting their cloths on. They are often painless and may initially go unrecognized, but some bites are painful and may cause burning sensation. Many cases result in small papule heals in days to weeks. However, in some patients, a deep skin ulcer develops at the bite site or over the course of few days with erythematous halo and necrotic center can progress to eschar. With basic wound management, the lesion often heals without scarring. Debridement should also be avoided in early stage of necrosis but may facilitate healing once the lesion is stable and well demarcated, often causes may require skin grafting. Okay. By contrast of brown recluse spider, black widow spider can often more pronounced local and inflammatory reaction due to effects of the toxin. They include muscle pain, prominent finding, abdominal rigidity mimicking surgical abdomen, muscle cramps more than 60%, wound ulceration is uncommon, and patients commonly develop nausea, vomiting within hours of the bite, making this an unlikely diagnosis of this patient. Okay.